I'll ask our new, most recent junior partner, Dr. Ted Wagner, to come up here. And he's done a fusion or two, a decompression or two in his life. And I'd like for him to address again one of those simple scenarios that can cause headaches for days on end in any given course. So thank you, Ted.
Today's group, what patients we're talking about today, has to do with the patients who do not have an isthmic defect. These are patients who simply have degenerative disease, and for the most part, we're talking about an L4-5 phenomena. That's what most of us see. This is an example. We're not talking about young kids. We're talking about the aging spine here today. So this is a approximately 70-year-old woman with severe low back pain, bilateral buttocks pain, radiating down both legs, bilateral numbness, can walk about a half a block. Again, the question is it vascular or is it from the spine? And Dr. Webb tells us we can put them on a bicycle and tell. But this is the X-ray. And in the X-ray here, we have a spondylo. And the spondylo is probably 4 millimeters in that shift, and usually it's at 4-5, and that's true here. When you take an X-ray and you take a study with an MRI, you see this markedly stenotic area, and it's usually encroached upon by the facet joints. In order for that to slip, I think you have to agree that we have an incompetent disc. And we have some incompetency of the facet joints posteriorly, and we have hypertrophy of the facets. And that combination sets up this problem. I think that many of us here would fix this in a similar way. And the question is whether you can stay at one level or do two levels. In this case, if we went back, it shows that you have pretty marked degenerative changes at 5-1 and with significant low back pain. This is what was chosen in this case. Now, this is a 1-year follow-up, and this is a case in which the screws have no halos around them. You have pretty good evidence of solid bone healing, which was done with the iliac bone graft. And I think that this is the case that we're sort of talking about today. And the question is, what are the mechanics of it? I really can't contribute anything today that is going to be surprising, but I want to share with you some of the research that I was involved in and looked at some of this stuff. This is an interesting way of looking at things. This is when the rods first came, when we were using plates initially and then converted to rods, what kind of stability did we have in this three-legged deal? And if my links work right here today, this is really what you have. So if you agree that you have an instability of the disc and you have some instability of the facet joints posteriorly, and you feel that you should use instrumentation, and you believe that rigid instrumentation will help you with your fusion rate, then I think we have to come back and address really what kind of instruments we're going to put in. How much instrumentation has been done that wasn't necessary? That's a huge question because I had a partner, Dr. Jim Tupper, who did 100 consecutive L5-S1 fusions without a pseudoarthrosis, without instrumentation. So the question is, how many of us right today would put instrumentation routinely to do an L5-S1 fusion? And that question hasn't been answered. So I think in the anterior pathology, we've got to break it down into the annulus. We have to break it down into the nuclear material itself. This is a slide borrowed from San Francisco, and basically looks at these components. We really have a nucleus, an annulus, an end plate, and a vertebral body. And it's pretty clear that we don't see much on a regular X-ray here, and as we move over, this is what we can recognize on a real X-ray. And by the time we get to here, we really have a grade 5 condition, and I think all of us agree that the disease is anterior and posterior. The facet joints, we have this loss of articular cartilage, and then we have this capsular component. And the bone spurring around the vertebral body forward in some of the anterior disc portion, and then we have the bone spurs posteriorly. I think that is pretty much what we have as the result of this. Now the question is, what happens to that segment? Does that become stiff, or does it have a lot of extra motion? I see both things. Patients I see with lots of degenerative disease don't go anywhere. I see people with lots of degenerative disease, and they slide all over. So I think this is like a lot of degenerative disease we see in knees, and we see knees that have a lot of instability and are degenerative, and some aren't. And we have to treat those individually. And these are the different pictures we get with the problem. Now, I think historically we've gone over some of the things today, and you guys have voted on whether we do nothing for this person with a back pain, or whether we look at it as a leg pain problem. And then we certainly can go back to decompressive laminectomies, and we can go farther back than this, but it really became an epidemic of laminectomies in about 1960s. And if we went to the posterior fusions, we started in the 50s, and at that time people were basically fused and put in a cast, and then gradually into bracing. So we went through this whole stage where we have fusions with internal fixation and bracing, anterior fusions with standalone spacers, fusions with anterior and posterior decompression, reductions of spinal deformity with A-lifts and PLIFs, etc. I don't think that you're going to brace the aging patient very well. I think that the lumbar corsets with some elastic compression seems to make some people feel good, and it's worth probably a try. I think any further bracing is pretty impossible. Exercise, I think, is real. I think a lot of people really can benefit from the exercises, but not when they become severely stenotic. The medications, I'm more worried about medications now than I was before. I have my own partner who has this condition, and he took occasional Modic and didn't feel well in February of this year. And his creatinine was 6.2. So he's in renal failure and took anti-inflammatories for a short time. Actually, not so short. He took it for about 3 or 4 months, but was only taking 3 or 4 a week. And so I'm pretty concerned about that. So then the treatment becomes more surgical. And I think you really have to analyze this in all 3 directions, and won't bother you, but most of them have been classically cantilevered models. And as we instrument them, we have some triangulated instrumentation that may help that. And then we have anterior support. And Dr. Bill Carson, who is a friend and has been out in Missouri, Columbus, has done a lot of the biomechanical workups for many of the instrumentations that have developed, and specifically done some for the DePuy spine group. And he wrote many papers, and one of them is on the parameters influencing spinal implant constructs, and I'll try to share a little bit of that. First, he felt that the objections were to identify other parameters influencing the construct stiffness, develop a means of predicting the stiffness of the spine, constructs with pre- and post-op measurements, and to help study the construct stiffness relative to the clinical observed problems. And finally, to help the clinical pre-selection of rod sizes and materials, which is basically to say is how much metal do you need to have in the patient. And I think that these formulas can get very complicated, and I'm certainly not going to, I actually tried to learn a lot of that from time to time. I was a physics major in college, but it still goes beyond me and pretty quickly. But this model that you're looking at on the right is the model we're really looking at as you instrument it from posterior. And it creates, this is in the worst scenario where there's nothing in between and you have a pure cantilevered system. And I think that just as a kid who played with Tinker Toys, the thing's going to break right here or it's going to break down here. And that's basically what happens. But if you study this, you can make formulas that will tell you whether it's at the screw flexion angles, whether it's at the rod flexion bending, or whether you're going to have a rod axial compression problem, or whether you've got a connecting rod bending issue. Many graphs can be drawn from all of this, and you can measure these stiffness and plot these out. And then you say, so what? But these are all deteriorating weaknesses that occur within the system. And then you ask the question, does the fusion stiffness, span adjacent disease, span bone density, correlate with the implant construction stiffness? And if so, is it clinically significant and useful for the treatment of decision making? And I think that the answer is yes. The stiffer that is, the better the fusion rate is, and that's, I think, an important part of the anatomical problem. If you lose correction of this, then you lose the anatomical decompression. So these are the lines. So I'm going to take you through a little experiment here in which we looked at several things. If you put a two together, you have this windshield wiping phenomena. And so you say to yourself, well, can we make the screws so rigid that this wouldn't happen? No, it's impossible to keep those screws. Those screws are turned in. They have very minimal resistance to rotating in the bone. And so this can occur. So the question is, how would we stop this simple problem? Well, when you had plates, you could run the screws in and triangulate it, and it's rigid, and it really is very stiff. So plates are really cheap. They're and work out pretty well. But as the modern systems have come out with rods, and you're looking at one level, we're talking about one level fusions now, there's a real indication that you may have to tie this together. And again, if you rotate this, how much resistance can you, how stiff can you make it by tying it together? And these are just some graphic pictures of what happens with it. And this is what happens if one of those is loose. So you can see that just tying one of them together will give you some stiffness, but the other side becomes really, really important. So then as you come over and go further, you have this, this thing where you can't bend this at all. So I think that this is pretty simple stuff, but it's pretty interesting that if we're going to look at the instrumentation and we're going to do this fusion, we make that commitment, then we have to commit to equipment that's going to go front and back. You have to get the posterior stuff right. Now, the whole story of adding anterior, So I think the question about this same patient with this disease is, can you make a mechanical disc replacement to treat directly the anterior pathology, but leave these posterior facets? Now, today's discussion would say that those facets aren't very important. Maybe they're more important if they're left degenerative and now moving. So now they are the source of this back pain that we didn't have before. And that's my big question with the whole disc replacement. I've seen a couple patients, probably seen a half a dozen patients who have had the disc replacements, actually different systems. And of course, I'm seeing them because they didn't do well, and they're asking for another consultation. And it certainly seems that those facet joints are going to be a critical problem in this same disease. So maybe it doesn't treat the disease, this 4-5 degenerative disease, real well. However, I really think that the Nobel Prize for spine surgery is not going to come with a mechanical disc. I really believe that we are eventually going to be able to grow some cartilage-like material up front, and that will probably come 5 years after the mechanical disc. And in orthopedics now, it takes about 5 years to prove you're wrong.